Hello guys, yes, welcome to my YouTube channel Let's Join Pharmacy. Yesterday in our part 1 of our Gpat, that is lecture 1, we discussed up to drugs with high first pass metabolism. Clear? Now distribution, it is the one more very important character of pharmacokinetic. Clear? Now what is this distribution? It is amount of drug distributed at the concentration measured in plasma. Means how much amount of drug is distributed, okay, at the plasma. Now for an example, you take 100 decimeter or 50 decimeter or 50 ml of plasma contains how much amount of drug, that is a distribution. If more amount of drug is entering the tissues, it has a higher volume of distribution. Okay, if the drug distributing to the tissues in heavy amount, in more amount, then the volume of distribution is more. Next one is, if a drug is highly bound to plasma proteins, it will behave like a large molecule and more likely to stay in the plasma. Therefore, less will go to tissues, resulting in reduced volume of distribution. See, one more very important point you have to remember. Now, if the drug is highly bound to plasma proteins, now this one is the drug. If this drug, if it is highly bonded to this plasma protein, highly bonded, closely bonded, then it will behave like a large molecule. Yes, obviously it behave like a large molecule and more likely to stay in the plasma. Due to the compactness and due to the large molecule, this will remain for a longer time in the plasma. So staying a drug a longer time in the plasma will liberate its therapeutic action regularly. Now therefore less will go to tissues, resulting in reduced volume of distribution. Means here why the volume is distributed, means distribution of the volume simultaneously, slowly. Why? Because the drug is adjoined, combined with the plasma proteins, okay, and they form a heavy molecule. So being a drug for a greater amount of time with the plasma, what it will do, it will release the drug slowly. Now drugs with high plasma protein binding, one of the very important character of the distribution. See, drugs with high plasma protein, some of the benzodiazepines, they stay longer in the body, okay, benzodiazepines. Then diazepam, in diazepam or chlordiazepoxide. See, diazepam, it is the sedation drug, and the action of this drug is a prolonged time. Why prolonged? Means because these benzodiazepine, they form the molecule or they form the highly bond to the plasma protein. For that reason they are in extended form. Then midazolam, these all are the sedative drugs. Then chlorpromamide, then talbutamide, cyclosporin, imipramine, verapamil, warfarin. These all are the drugs which have high bond with the plasma protein. Plasma protein binding makes a drug long acting by reducing its metabolism. Very important. See, plasma protein, due to the combining the drug with the plasma protein, what happens? The metabolism decreases. Okay, liver cannot metabolize these plasma and drug very fastly, so metabolism is decreases. If metabolism decreases, means the active form of drug can be increases. See, one of the very important point here, dialysis is not effective in drug. You know the dialysis means what here? Removing of the waste product. If your kidney unable to remove the waste products, then we are doing dialysis to remove the uric acid crystals or to remove the waste products from the kidney. See, dialysis is not effective in the drug. If this drug is present during the dialysis, they cannot be removed. Which see, amphetamines, one trick is there, avoid dialysis. A means amphetamines, V verapamil, O organophosphoids, I imipramine, D digitalis, then dialysis, that is diazepam. These all drugs you cannot remove, okay, through dialysis. So dialysis is not effective in this if these drugs are given. You cannot go to the dialysis, you can prefer another method. Okay, I will tell you the method. See, this one is very important. Sometimes they will ask dialysis is not effective among the drugs. Which are those? You have to remember this. Avoid dialysis: amphetamines, verapamil, organophosphates, imipramine, then digitalis and diazepam. Next is a dialysis removed only those drugs which are present in sufficient free concentration in plasma. Okay, dialysis, it is only helpful if the drug is present in the free form, not joined with the plasma protein. If the drug it is in free form, not joined with the plasma protein. Okay, if the drug is in free form, then only it can be dialyzed, then only it can be removed. Thus, drugs having a high volume of distribution, more in tissues but less in plasma. Those drugs, they having the high volume of distribution means they are more in the tissues and they are less volume in plasma. Why? See, if the drug is not in free form, then the volume is distributed where? More in plasma. Why? Means because the plasma protein bonded with the drug, so more in plasma, so less in tissues. But here, due to the free concentration of or free drugs in the plasma, means what happens, the volume to the tissues get increases more in the tissues. So drugs having low volume of distribution and low ppb, that is a plasma protein binding, are good candidates of dialysis. Those who are low volume of distribution, they are very good candidates. Example, salicylates. For an example, paracetamol, aspirin, you can easily, aspirin it is a weak acid, so you can easily remove that one. Then volume of distribution. Next concept, our volume of distribution can be calculated by dose administered to plasma concentration. Chloroquine is the drug with highest volume of distribution. Chloroquine, anti-malarial drug it is one of the drug with highest volume of distribution. Some of the pro drugs are discussed here. See, plasma, plasma makes certain drugs powerful. Pro drugs. Now what are these pro drugs? We will discuss here. See, metabolism. Our next characteristic is metabolism of pharmacokinetic. See, the primary site of metabolism is liver. You all know that liver plays a vital role in metabolism. Most of the drugs are inactivated by metabolism, but some may be activated from inactivated compounds. So you know that the function of the liver is to inactivate the drug. Many drugs are in activate form, so the liver break down them and convert to inactive form. Now some drugs, so they get active from inactive form. Some drugs may be activated from inactive compounds like prodrugs. Now what are these prodrugs? The drugs which get activated from inactive form with the help of the liver. Prodrug example, prednisone, levodopa, then ACE inhibitors, except captopril and lisinopril. Okay, these captopril and lisinopril, these are the ACE inhibitors, but these are not prodrugs. These are not converted from inactive to active form. Then sulfasalazine, meraptopurine, then aciclovir, methyldopa, clopidogrel, carbimazole, cyclophosphamide, dipivifirine, then proguanil. These all are the very important prodrugs. They are converted from inactive to active form with the help of the liver. This plasma makes some drug more powerful, some certain drugs powerful. Now metabolism, you come through this metabolism. Microsomal enzymes may be induced or inhibited by other drugs. See, microsomal enzymes, they may be induced, increases, or they will decrease the effect, okay, of these enzymes by other drug. Enzyme inducers means those enzymes which will increase the effect of the metabolism, like GPSR cell phone. G means grisoflavin, phenytoin, rifampicin, smoking, carbazimapine, phenobarbital. These are the enzyme, means these are the drugs which will induce the enzyme inducers. Grisoflavin, it is the antifungal drug. Phenytoin, you know that it is the phenobarbital. Then rifampicin we give to treat the TB patient. Smoking, carbazimapine, yes, it is also carbazimapine which used in the seizures. Then phenobarbital. Then enzyme inhibitors, those drugs which will inhibit the enzyme activity, that is vitamin, that is valproate, ketoconazole, cimetidine, ciprofloxacin, erythromycin and INH. Vitamin K, trick, vitamin K cannot cause enzyme inhibition. Now some inhibitor means enzyme get inhibited by these drugs. Remember this one, very important points. Then see, this is also very important. Now one point I want to tell you, see, I have told there, if dialysis cannot remove those drugs which are bonded with the plasma protein, then how can we remove that drugs? Means by using some of the other drugs. Okay, those drugs, what they will do, they will break down the adjoinement of the plasma protein and that drug, plasma and drug. Clear? The additional drug what we are giving, no, that drug what you will do, it will separates the plasma protein and drug. So drug will become in the free form, we can remove the drug. Clear? Now after phase 1 reaction, drug may be water soluble or lipid soluble. You know that metabolism, there phase 1 and phase 2 reaction are very important. After phase 1 reaction, what happens? There may be drug may be either water soluble or lipid soluble. After phase 2 reaction, all drugs become water soluble only. Okay, all drugs become water soluble, which after phase 2 reaction. After phase 1, either they can be water or lipid soluble. Then some of the metabolic reactions, see phase 1 and phase 2. In phase 1, both these microsomal as well as non-microsomal enzymes will act. Where? In the phase 1. Example for phase 1, that is oxidation, hydroxylation, dealkylation, deamination, reduction and hydrolysis. These all are the mechanisms here in phase 1. Then in phase 2 is microsomal, non-microsomal. See, phase 2 reaction, it is conducted by some of the microsomal enzymes. In that microsomal enzymes like glucocornoids conjunction. Then non-microsomal glucothione conjugation, acetylation, methylation, sulfonation. These non-microsomal enzymes act these all things in phase 2 reaction. But in phase 1 reaction, both enzymes like microsomal and non-microsomal. Microsomal enzymes like which one? Cytochrome P450. These all are the microsomal type. These both micro and non-micro act in phase 1, but in phase 2 they again divided. Microsome only act on glucuronides, that is conjunction. It is the most common type of the phase 2 reaction. Then glucocornoid conjunction is catalyzed by microsomal enzymes. I told you glucocornoid conjunction is catalyzed, breakdown by microsomal enzymes, then but not by cytochrome P450. Cytochrome P450, it is also a microsomal enzyme, but this glucocornoid conjunction, it cannot be catalyzed by cytochrome P450. Okay, other enzymes help to catalyze this one. Next is excretion. This excretion, our last topic where of the pharmacokinetic. After this excretion, we go to the pharmacodynamic. Only one point you remember in excretion, the major route of excretion is kidney. Clear? The remaining part of the excretion will be discussed in the next video. There we will cover half-life period and excretion. That is very important video. So if you like this video, then share, subscribe our channel and like it. Thank you.